Welcome, everyone. I am Zubin Shroff from the Alliance for Health Policy and Systems Research, WHO, and today's session focuses on how participatory systems dynamics modeling can help us think more clearly about complex health system problems, and in particular, how to improve cardiovascular health outcomes. Thank you to all of you for joining us. And I'll begin by briefly walking through the session and situating today's webinar within the broader health systems impact modeling consortium work that the Alliance is implementing in collaboration with Health Systems Global. Could I have the next slide, please? So I will begin with a short overview of the Health Systems Impact Modeling Consortium and the rationale for this webinar series. We will then move to the main presentation led by colleagues from the Swiss Tropical and Public Health Institute. After that, we will hear practitioner reflections, followed by question and answers posed by Professor Tim Robertson from the University of Western Australia and myself, followed by questions from the audience and some closing reflections from Professor Tim Robertson. And with that in mind, let me briefly introduce the consortium and why this work matters. Could I have the next slide, please? So this webinar sits, as I said, within the broader work on health systems impact modeling. And very importantly, the focus of this is not just the technical modeling, but also about building a field and a community, about connecting researchers, policymakers, and practitioners about the use of modeling approaches to inform health system strengthening efforts. Could I have the next slide, please? So the starting point for this is a fairly fundamental challenge. We need better ways to understand how the impact of investments in health systems interventions on service delivery, health outputs and health outcomes. And we aim to nurture the development of modeling approaches that can help explain the impact of health systems interventions on the provision of essential services. A second objective is to lay the foundations for a learning ecosystem that brings policymakers, researchers, and development partners into closer dialogue about this. And this work is really two components. First, country modeling studies, and second, a broader community of practice developed in collaboration with Health Systems Global. Could I have the next slide, please? So looking at the country modeling studies, these countries modeling studies were selected through a competitive research call for research proposals, and we're supporting 3 countries do this to answer modeling questions that matter for health systems practitioners. And really the questions themselves and the way these studies have been framed have been designed in close collaboration with policymakers in each country who are involved with an active national technical consortia that gives us ongoing feedback to ensure that we are aligned with policy questions and policy challenges. So in Ethiopia, the work looks at the financing reforms for NCDs, including particularly the community-based health insurance and how fee waivers, provider reimbursement affect the control of NCDs. In Indonesia, the focus looks at on NCD service delivery and how shifts in drug supplies, task shifting and referral pathways influence access and utilization of care for diabetes and hypertension. Cascade modeling approach. And in Kenya, the work looks at the community health promoters, paid community health providers, and how shifts in supplies, workforce numbers, and training can influence their ability to provide packages of services. And we're using a diverse range of approaches. 2 of these use systems dynamics modeling, which we're also going to see another example of today. And the other study in Indonesia looks at a cascade model approach to answer this question. So we're thinking of, and as I said, could I have the next slide, please? With really important, in addition to the modeling itself, is to ensure this is easily communicated to policymakers and development partners. And when important priorities to translate model outputs into formats that they can actually use. So practical interfaces, clearer communication results, and these have been also co-produced with these national policymaker consortia. We are also developing a supplement series of research articles in the journal Health Systems and Reform, informed by this program of work. And finally, of course, there's an important convening function that this research program is carrying out. We're planning a satellite session at the Health Systems Research Symposium and to reflect on how health systems modeling is evolving and what are the larger lessons from the program as a whole beyond the 3 individual country studies. Could I have the next slide, please? Beyond the country studies is our close collaboration with Health Systems Global on developing a community of practice. And we want to create a space where current work in health systems modeling can be discussed, debated, and shared, which is very much the focus of events like today. And this is intended to sensitize a broader community within the health systems research community on the potential of modeling while encouraging exchange across projects, countries, and disciplines. And we are creating a repository, and you'll have the link for the repository on the next slide. Go to the next slide, please. We have created a series of webinars. This is the third webinar. We've had more discussion format linking and learning sessions. The last one was held in December, and this repository of resources on health systems modeling, which is not only a dissemination channel, but we intend as a living platform for exchange. So this is an overview of this work, and with this framing in mind, it is my pleasure to introduce the three speakers for the main presentation. First, we have Dr. Daniel Cobos, a research fellow in the Health Systems and Policy Research Group at the Swiss Tropical and Public Health Institute. And Dr. Cobos is a medical doctor specialized in family health and community medicine with a master's degree in public health from the London School of Hygiene and Tropical Medicine and a PhD in public health. With him is Pei Shan Loo, a systems dynamics and computational modeler working at the intersection of health and social systems, with a background in public health and peace and conflict studies and extensive experience in migrant health and protection across Southeast Asia. And our third presenter, Wang Zhao, is a scientific collaborator at the Swiss Tropical and Public Health Institute, whose focus is really on using systems dynamics to model and analyze public health policy related to non-communicable diseases. So I'm delighted to invite Daniel, Pei Shan, and Wang to take us through today's presentation.
Thank you. Thank you so much, Subin, and thank you to the Alliance and Health Systems Global for inviting us to present this work. And before we start, just to say that the work that we are going to present is the result of the contributions of many people. In the core team was the Swiss TPA, the Beneficencia Portuguesa, and the Novartis Foundation, but then the Servicio Único de Salud in Sao Paulo, medical societies related to cardiovascular disease and hypertension in Sao Paulo and Brazil participated. So this is a collective effort, and the acknowledgement goes to all of us. We are the spoke people, let's say, of this effort. If you go to the next, please. So this is what we are planning to present today in the 30 minutes or so that we have. So I'm going to present a bit more on the why do we do this, how do we approach health system modeling from a high-level perspective. Then San will go a bit in depth into participatory model building. So how do we manage to build these type of models in a participatory way, bringing everyone on board, and then hopefully everyone using it at the end. And then one will bring some of the data innovations that we are doing right now on how you bring a model developed for one city, for one context. How can you scale it up or contextualize in other settings? So this is kind of the overview of the presentation. If you can go to the next and next. So in our group, so we work at, our group is called the Systems Innovation Group, and we basically what we do is we try to unpack the complexity of health, well-being, and health systems challenges. And for us, this type of cascade of care, where you have people that is not sick and become sick, then they should be screened, diagnosed, and then treated. It's a cascade of care that repeats in many different conditions or for many different conditions. And we are using this cascade of care as the backbone of what we call the simulator, that is a system dynamics model to understand the dynamics of hypertension in a city like Sao Paulo. And even though it looks simple, so patients will go through this cascade. If you click, the reasons why people get sick, they should appear now. The reasons why people get hypertension are very diverse. So it's because of the way of life, whether they have sedentary life or they have the wrong choices in diet, or whether there are local health initiative for earmarked taxes for sugary products, or depends on the work that the private healthcare system is doing in preventing this type of condition. So it's a mix of factors that influence people getting sick. But then if you click, But then once they are sick, like the reasons why people get screened in a health facility depends depends on many different factors, because maybe they live far away from the health facility. Maybe it's like hypertension is a condition that doesn't give any symptoms until it's really developed, or maybe they don't care. Or they are not aware that this is even a condition. But once they are screened, they need to go through the full process of diagnosis. If you click next. So then why people get diagnosed, it again depends. It might be because the diagnostics is expensive for them. They cannot afford it. It might be that the health professionals do not know the protocol for diagnosis and they don't apply the current evidence. It might be because there is a stigma associated with that condition. And then finally, when we come to the treatment, if you click again, the fact that people do not get the full treatment or get the full benefit of the treatment may be because they don't adhere. And in chronic conditions like hypertension, this is very frequent. People go in and out of treatment very often, depending on whether they have symptoms or not, whether there is continuity of care, or whether there is social support to continue that treatment. So this to say that even though the cascade of care is simple, the factors influencing why people move through this cascade of care are complex. So from us, from a complexity point of view, our idea is that first we need to unpack what are these factors, and then ideally we want to quantify it. And this is where system dynamics modeling as a tool becomes very handy, because we can do this entire process of unpacking, understanding, quantifying very easily, and then producing analysis that can be helpful for policymakers. If you go to the next and click again. So, and the reality is that there are health system challenges or health challenges. They come with lots of uncertainties, and we tend to oversimplify our realities, and we all do this. So we tend to think in cause and effect in a very linear way. And I'm sure that I'm preaching to the choir here, but we don't acknowledge complexity of problems very often. We like to live in a simple way, and we tend to believe that the reality is like that, but it's not. If you go to the next, then the second part is that if you put in the shoes of a policymaker, the amount of evidence that exists for some of these challenges is massive, and for cardiovascular disease and hypertension is massive. So how do you make sense of competing evidence, all these different factors, how these different interventions create synergies or barriers? Like all of that is out there, but is not being used. You go to the next. Then also the reality is that the human being is not very good at predicting things. And well, I'm not going to say anything. But the reality is that there are many dynamics in populations, in health systems, in diseases that we need to acknowledge. And for example, in Brazil, population is getting older. Only that will impact hypertension management, will impact hypertension prevalence. So only population structure will impact, but there are many other dynamics that are changing over time. We need to understand them, and we need to acknowledge them in our planning processes. You go to the next. Then when it comes to what is the problem, depending on who you ask, you will have different answers. I remember discussions with the medical societies in Sao Paulo, and a big discussion was about the single pill treatment for hypertension. Like that was the thing that they were thinking, okay, this is the problem, that we don't have this. But then when you ask people working in primary health care, sometimes the problem is access to the health facility, or that people cannot come to the health facility because they are working and they don't have the time to come when the health facility is open. So depending on who you ask, you will get different perspectives. And we feel that participatory model building really brings this discussion exposes these differences and these discussions and bring them into the surface. If you go to the next. Then the five challenges that we see is that systems, is there a way? Oh, sorry. The next part is that sometimes when we do something in a health system, the impact will come 2 years down the line. The impact will come down the line. And again, human beings are not very good at projecting impact at projecting effect. So with system dynamics modeling, we are allowed to project this impact for the next 10 years, for the next 20 years, for the next 40 years, which is very useful when you are discussing with a policymaker. It's true that sometimes policymakers, they have a limited time span that they are interested in. Basically, it's when they are in office, so 4 years or 5 years. But then there are other opportunities where showing impact over 20 years with all these feedback loops makes the difference. And then last point is that we cannot test everything in real life. So if there are so many combinations of interventions to improve hypertension management that we cannot test them. It's very expensive. It's probably unethical, and we will never get to these conclusions. So what system dynamics bring into the picture in this area is the ability to create the scenarios, the ability to have a virtual policy lab where you can say, okay, what if I do A and B? What if I do C and D? What if I do nothing? What if I do 7 options? So you can test different scenarios, different policy options, using an agreed and robust model behind. If you go to the next, you click like 6 times. So then this is just a summary of what system dynamics modeling can do for you. And now you click the play. And this is just an example of how the system dynamic model that we have created for Sao Paulo works. So you see that there are interventions on the right-hand side where it says simulation panel. And then at the bottom, you see a graph that shows the impact over time in different indicators. In this case, is diagnosed. And you see that now there are 3 lines. The 3 lines are the baseline data, what if we don't do anything, and what if we double screening. And you see how in the panel you can change, okay, what is the capacity of a screening corner? What are the number of screening corners? So you can change different variables and you will see the impact over time of doing that. And to me, I'm not a modeler, I'm a public health person. To me, this is the amazing tool that I've never had when I was in a district health office or supporting the Ministry of Health. The ability to see the what-if scenarios for different interventions that we are discussing. Because I don't know how many of you have been sitting in planning processes, but many times it's like, oh, I think we should do this, or oh, I think we should do that. Or there is someone with specific interest or capacity that if I work on a screening, then the activities that I want to propose in the plan are screening related. So this tool allows for looking at the different variety of activities that you can do, the different interventions, to modify the scale of those interventions. So do I want to do it for all health facilities, for 1 health facilities, for 3 health facilities, 50%? So you can change many, many variables and you see the impact over time. And now, if you go to the next, now we are also adding not only health outcomes, but also economic outcomes to the analysis. If you go to the next. Yeah. So but the thing is that this tool cannot be something that like 3 people in Swiss TPH does and brings to Sao Paulo. So we need to, and San will talk about the participatory modeling part of the exercise, but the other part is creating confidence on the tool. And you see in these graphs, this is the cascade of care, and you see the black dotted line. This is historical data. This is the historical data in Sao Paulo for undiagnosed, diagnosed, treated, and controlled. So this is the trajectory. And then the simulator, or the system dynamics model, simulates that trajectory and projects it over time until 2041. But you see that and this is the red line, but it's not a line because there is uncertainty around the estimates that the simulator produces. These are estimates; they are not data points like the black dotted line. So you can see not only that it fits the historical trend, but also that there is uncertainty around those estimates. If you can click next. And part of the insights that you get by using the simulator are like this one, where people have mental models on how things happen or how things change, but then they start changing things in the system dynamic model, and they say, look, I put everything to the maximum and the prevalence of hypertension doesn't change. Yeah, because if you don't do prevention, you will have hypertensive patients coming in the cascade of care, so you will never reduce. So those type of insights by using the simulator are also crucial to plan properly for to reduce, in this case, hypertension burden. You click next. Click next, please. So then, just to finalize the part that I wanted to present. So this is the type of output that we get from the simulator. So you see here in rows, you see different type of policies, different type of interventions. So you have the baseline, double screening, cardio interventions, health system focus interventions. Those are in rows, and then you have the impact on the different parts of the cascade of care in columns. And you see the darker the color, the more impactful it is. That just by looking at this, you can see how some interventions have impact primarily on screening and diagnosis. Some other interventions will have impact all the way to cardiovascular disease event. But you already see like what are the differences. And this is already very insightful. But then if you click next, usually we need to translate this into policy documents that then policymakers, decision makers will take and will feed into the policy process. And this is the example of a policy brief that the team in Brazil did with the results of the simulator to inform the strategy in the municipality when, related to cardiovascular disease. If you click next, and this can kind of click next. Sorry, but yeah, and this can spill over into not only policy documents but also into the news. And this was in the case of Aracaju, that Yara and the team went there to adapt the simulator to a different city in Brazil, and what got lots of attention by not only the municipality but also by the media. You click next. So this is just to finalize, is that from identifying the problem to building the simulator to bring policy products that are useful and interesting for the discussions, there is a lot of work in bringing everyone together. And I think this is the segue to pass it to Sam. You click next.
Yes, thanks, Dana. I will now continue a bit on, maybe some of you are asking the question, what is behind it? Because from our experience that talking with different stakeholders, some stakeholders are really high level understanding, okay, this is the main result, we are very interested. But some stakeholders really questioning, okay, what is behind the interface, the interactive interface? We would like to understand more. Or what do you do in the process of having this model? Or people will ask, what is actually system dynamics model? This is not a term that I learned in my work or my job. So in this section, I will take these 4-5 minutes to share with you a bit of how do we bring or collaborate, work together with the stakeholders throughout the model building process. How do we have this iterative validation process with the stakeholders to build the trust, to build how they could use the tool, not just for the project itself, but also outside of the project. And also a bit of the model adaptation process, which involve our partners very closely. Next, please. Now, come back to the words. If you're thinking, okay, that's not the word that I know, you just split it into two. Basically, the point is to understand the system. This word is to understand how things connect to each other, for example, the ecosystems and all of that. And the next is dynamics, how we want to understand the change over time, which means next is the overtime graph. We want to see the change from the past, which we use historical data, present, 2026, and the future, we project into the future. So this is an overtime graph that we all are very interested to understand at the population level. What can we do in different part of the system, finding the leverage points to impact the way that the indicators that we would like to see change. Next, please. And sometimes it could be as simple as a background idea of a bathtub, or I call sink. The basic concept of system dynamics models is the inflow and outflow and the water level changes. So in the next slides, I will show you a bit of how do we connect many bathtubs or many sinks together, and how the change of one flow to the other is actually replicating or to show the complexities of the cascade of care. Next, please. So here, if you click next, maybe you can slowly click next. Yes, here you can see different boxes. Here we call stocks of population. And you can start with the first is the population with normal blood pressure. We're going into the cascade of hypertension. Of course, when you have normal blood pressure, you stay in normal blood pressure unless you start to onset to have pre-hypertension, then you move into undiagnosed pre-hypertension population. Then if you're diagnosed, you move to diagnosed. If you're treated with behavioral change, then you move into treated. And in this part of the model, you can actually still go back or flow back to the normal blood pressure, right, with the lifestyle behavioral change. However, if pre-hypertension progress, it goes into hypertension, where there is not a feedback loop back to a normal blood pressure. So here we also see more clearly the undiagnosed, the diagnosed, the treated, and then you goes into the control, which many, so if you click next 2 times, it goes into the controlled, which many of the downstream health system, diagnostic treatment, adherence, to really want more people to be in a control state. And of course, we have to also understand adherence is a problem. So there will be people in the dropout. So Dana likes to use the room. So you will see prevention interventions for targeting on that upstream part of the cascade. And next, if you look into diagnose, it will target the middle part. And lastly, the treatment is targeting the downstream part of the cascade. So just to give you a very overall idea, usually when we talk with our stakeholders, if they hear about system dynamics the first time, this is how we share about the core structure of the structure. And this core structure doesn't come from us. It comes from the process with our project, which I will describe a bit more later. So it's to not just put different literature together, but also understanding the data structure available that will come out with this core structure to understand. Right, next, please. Yes, so what you have seen just now is a very simplified level of the core cascade structure that we have, where you see the population, they go into different part of the core structure, and the cascade of care data goes into the cascade stocks in between. But in reality, the model structure is slightly more complicated or complex than what we saw just now. So you can see there, in the model, we are translating this complex insight, because sometimes within 15 minutes discussion with the stakeholders, we might not be able to explain every single structure. So we go on to a simplified interface. If you move on to the next one, which Dana has talked about, so I will not go on into this furthermore. Next page. Yes, if you can click continuously slowly. So this is the overall idea of the process, where it started with identify a challenge. Whose challenge are we talking about? Who are the user of the model? Then from here, we have more of a participatory kind of workshops to understand different stakeholder mental model. So they could tell us, okay, the factors for Sao Paulo is this, and the policy is this here, and we want to explore the other policy. So this is the more participatory way that we get inputs from stakeholders. And next, we quantify it into a model, which you have seen the model structure just now. And next, that's the, yes, and next. Yes, if you click 2 more times. That's good. So that's the whole process of the model building, and this is where the stakeholder come into all stages of the process. Good. Next, please. Now, we started the model with Sao Paulo, with our partners Yara, Mariana, and the team Medical Society, and everyone worked together on building the Sao Paulo model. After this, we also realized that, the project is also needing some design or planning of interventions in other areas. So Aracaju is the next place that the model is adapted to. So with this, we try to also understand what and how can it be done. Overall, the core structure remained rather similar when we are adapting. And of course, we don't just go to the other places and say, use this simulator. We also bring in the stakeholders together to say, okay, if this is the data that you need, or if you have other database that you would like us to look into. And what I remember quite strongly about is one of the situation, I think, with Tiara Mariana, after the reflection with the City Hall in Aracaju, they were asking, are you overestimating the impact of a particular interventions? And from there, they're sharing, usually this is the impact of the intervention. And from our side, we also come back to really check and see, okay, the results show is very similar to the impact or the effect size mentioned. So these are the iterative process where we try to understand constructively and critically on the model so that the local stakeholders could also really trust and build that ownership of the adapted model. Next, please. So I have mentioned a bit of how it goes with the data collection, adaptation, policy brief, and a lot of different types of stakeholder engagement. So this is a brief overview of the process from my side. If you click next, I think this is, next, please. So that's all from my side. I will now pass it over because as you can see just now from the world map, we have adapted to 5-6 cities, but now we are also looking into adapting to even 20 cities at the same time. But for us, it's very important the human factor in this case, and also the uncertainty that we're trying to reduce so that we can increase the confidence of the simulator and work very closely with the stakeholder in this participatory model. But I will pass it to Wang to share a bit on how do we deal with the uncertainty part of the model adaptation.
Thank you, Sam. Thank you very much. So if you can please go to the next step. Okay, so here I'm going to use the same layout. Sam was just sharing to share how we are working on these next steps here. So the context setting here is that we are entering a stage that we want to adapt to multiple cities in the world, in different countries, and we are actually doing this in a quite parallel way. That means we are not doing this one by one city, but we try to roll out it as a batch. So, but to be very clear, this is not to replace the iterative and the interactive adaptation process that Sam just described. Human factors are very important and the most important. We're never going to be replaced by other processes. But here, we still find it very valuable to have an initial version of the simulator informed using public data rather than so that can be helping and facilitating the initial engagement with the local stakeholders to give them the idea and share with them the applicability of the simulator so that making the initial engagement more efficient and effective. So for that purpose, we are exploring how are we going to use the public open data from previous leading researches to inform the simulator so that they can be more relevant from one country, one city to multiple country, multiple cities. So here is where we scaling up, going to scale up. So if you Could please click next. Yeah, so the picture here are showing a few steps here. So as we have been talking through, we are informed using literature. We are informing the simulator when going to multiple countries and cities using the literature first, but we also bring in public data, and we also carry out the expert review. But in the end, we will also present this to the stakeholder in their engagement and interaction with them. So the stakeholders are playing a super important role here, because they will be able to tell us, hey, this is the data we have on our local site, as Sandra explained in her Arakaji example, and they will also be helping us outlining the scenarios that are most relevant to their city that the simulator can help them explore. So if you can please click to the next one. Yes. So this figure here shows that shows intermediate results that we are having when we are scaling up. So instead of doing city by city calibration with very fragmented data sources, we leverage the data sources including NCD risk, including the IHME global burden disease and UNWPP data, and adapt our model to multiple cities using a statistical inference method. So the purpose here is to standardizing the multiple city calibration workflow. So this is the primary funding of the calibration process, with the uncertainty interval that when our simulator is informed by the public data. So you can see the public data does help us to shape the trajectory into the future, and the public data does tell us what are the potential uncertainty ranges our calibrated model simulator will be projecting. So these are very intermediate results, but they are able to tell us about the potential scenarios. So can you please go to the next one? But we also need to make sure that our model needs to making sense in two different aspects. So first of all, the model simulation trajectory, the projection into the future, needs to be aligned with the best informed historical data trend that shows it. So this is where we bring in the first check. The first check is to compare the data uncertainty, which we calibrate to, with the calibration uncertainty, which our model produces. So here we can see the two different color of stripes. So the blue is, so this step is about a face validity check, and the blue stripes are simulation data. So they tell us after calibration what the historical data, which are the black dots, can help us reduce the uncertainty of the parameters too. So this is what kind of, how much information we can absorb from the historical data to reduce our uncertainty. So this is to be compared with the gray zone. The gray zone is 95% uncertainty interval of the historical data. So, but we must here outline and highlight the limitation. This is not the most strict comparison we have ever seen. And actually, the data carry different statistical meanings, so that we try not to say they are comparing in the in a very strict sense. The historical data is Bayesian model estimated data. They have their uncertainty interval, and our data is simulated data. They correct the payoff surface, so that these two, when we are overlapping them, we are giving a face validity, answering a very simple question: does our model simulated calibrated data be very off from the history? So if they are not very off, we move on to the next step. So can we go to the next slide, please? So then we enter step 2. Here we take a closer look, a closer review of the estimated parameters in the top 50 results from each of the countries adapted, so from each of the cities calibration. we use a multi-start method, which gives 500 starts in the overall parameter space. And we take the 500 top following the GLUE framework. So here we take a deep dive into the parameter uncertainties, and we review them, asking domain experts to give the review, to give the opinion. So you can see in the top of the field parameters, they are very well identified. They're concentrating. So that means no matter where I start my estimation, they actually converge to the same range. But soon moving down to the rank, we can see the parameters are actually according in all the calibrations, parameters spanning quite wide. So, but this is not the whole picture. The whole picture is we need to check how parameters are correlated to each other, and then this gives us the second and the third diagram, and this shows us which questions can we ask in the beginning regarding which parameter to the local stakeholders to get the most useful and most important information most needed to reduce uncertainties. So this is where, if you could please go to next. Yeah, this is where we are, the subject matter experts and even the stakeholders should come to the picture, because their input will be of critical importance in the next step to reduce the uncertainty. So this is my part.
Thank you, San and Wang. And I think we got lots of information, and happy to get questions from the audience and from the team. Thank you so much.
Thank you very much, Daniel, Pei Shan, and Wang, for rich and thought-provoking presentations. You've shown not only the technical value of participatory systems dynamics modeling, but also how these approaches can support policy dialogue and context-sensitive decision-making. So we'll have question and answers after this, our initial conversation on practitioner reflections. So it's my pleasure to introduce Dr. Yara Baxter. Yara is a senior health systems consultant with more than 40 years of experience across public, private, academic settings. She holds a PhD from the University of Sao Paulo and is closely involved with the Cardio for Cities initiative. She's been working with the implementation teams in Swiss DPH along with city governments to translate data into action and strengthen more integrated and sustainable health systems. So Yara, thank you for joining us. We're very much looking forward to hearing your reflections from a practitioner perspective. So I have two questions for you. The first is, how was the simulator and outputs translated into policy relevant insights for different audiences such as policymakers, clinicians, and civil society organizations?
Yeah, hello everyone. Thank you. Such a pleasure to be here. And I am really, it's an honor to be also working close with such experts that are just have done the presentations, which I can say that during these times, we are all learning a lot. And I started from scratch. I mean, I was not aware about the simulator per se, and now I think we are dealing with the complexity of putting it into practice. And the question regarding how is this being perceived, for instance, by policymakers or the clinicians or medical society, and being aligned with all my colleagues have presented, I have to say that we started from the medical societies. And it creates the trust of the simulator per se, which means that they were not aware about the simulator, but they were really start thinking about the process and all the consequences of one actions and other. I think we all have learned a lot about that. And what we can say regarding when we have all the results already as presented by them, it make it easier. I mean, we could put it in a policy brief and present it among policymakers, people, and they were in the beginning, because I'm here to talk about the practice. They were very excited. I mean, when we presented the policy brief and say, based on the simulator, this is what we can expect. It is a lot of information when we can say, based on your own data, we can organize it with all the complexity we know about the health system and show this is the way we could be accelerating the impact on the community, accelerating the impact of the best way to use the resources, the public resources. Then it's a lot of information, well received immediately. But I'd like to say that in the beginning of the process, it was a mess. I mean, we were learning with Daniel's son about the system, and we started sharing the backstage of the system and all the complexity that Sun just presented here. Then I can say that the impact was very not well received, because when we are presenting the backstage of the system, we are talking about all the technical aspects of the system and not the value that the system could be providing. And then we can say that before we were explaining the model, focusing on the simulator itself, technical explanations, and then we were perceived as bringing more complexity in our chaos that we already know, that are the system, fragmentation of the data, a lot of different model of collecting data from the field, and at the end, very low engagement. This is the way we started. And when we are saying about low engagement, we were losing a year because of we have started on this way. Then we keep learning, we till today, but we kept learning more. How could you make this simple? And then we started focusing on how could be enabling decisions and focusing on outcomes and priorities, and make clear where to act, what to expect, and being part of the decision support tool. Then we created immediately a strong engagement. Then back to your question. Now we can be talking about policy relevant insights. Yes, we can translate the model into decisions, but not focusing on the methodology. And we created policy briefs for São Paulo and Aracaju that Daniel showed, then focusing on priorities, impact, resources optimization. And also at the end, we are pushing them to improve the quality of the data, because then we could be working with all the level of the health system, not only with the highest level, where in the beginning we were supposed to be, but in the front, when we are pushing them to collect a better data, to be aware, to be aligned with what the presentation about the average that we could be working, then we could be narrow the distance of being more reliable at the end with the data. Then with that, we could be talking with the media, for instance, as Daniel said, because they are understanding the complexity translated into very simple message. If we keep doing what we are doing, we will not be facing the outcomes we are expecting. But if we are catalyzing the efforts on this way, put more efforts or more resources or more education on this way, we could be improving that. And now we are in Lisbon, and we can say that it's very different scenario if we compare with what we are working in São Paulo, Fortaleza, Aracaju, and so on. And we are also learning that based on the simulator and the expected outcome, we will be adding more efforts in, for instance, screening, in treatment. And they have a very high level of deliverable regarding the clinical outcome, very positive clinical outcome, even higher than the best data in the references, in the best reference, for instance, Canada. But we can see a lot of opportunity in screening and put the population into the system because they are outside the system. And the simulator was the tool that showed it to us.
Thank you very much. So I gather a couple of things. So one, of course, you're talking about the need to not bring in more chaos, and that's something with complexity you may actually confound policymakers. Your reflection only for simple messaging, but also interesting your observation that you actually pushed through this to improve the quality of data and finally how things vary across different contexts. And any other lessons you'd like to reflect on from communicating with different end users, be they policymakers, clinicians, civil society organizations? And you mentioned in the beginning the clinical groups. Anything particular about those groups?
Yeah, now they are discussing the simulator as if they were experts, which means they are engaging with the solution. I mean, they're not exactly the tool, but it becomes a solution. And also we can say that it makes the narrative very easy or easier to the media to better understanding. And we can circulating among all the levels of the system. I mean, the civil society, the most operational level of the health system, and the highest level of the health system. And also we are now in a very important discussion with the Instituto Fiocruz, which is the highest institution, yes, I know you know, but for the audience, the institution that is linked with the government, and where we are now working with the Swiss TPH and them to share knowledge and the technology transfer. We are working with the cities and so on, but we can understand that they will not be able to receive that technology to use, for instance, in a cancer patient, in other situations. And the simulator, as far as we are understanding, based on some lessons, we can say that we have to adapt it, customize all the back information of the simulator with details regarding the causal loop, which is, for instance, in cancer situations, someone there in Brazil, for instance, or in Portugal and so on, they must be aware about the technology, understanding how to do that, and then implementing it in the situation they need, in a sense of prioritizing the government directions. This is where we are now. We are sharing technology, or we are organizing the scenario to be sharing the technology to Fiocruz being the owner of the technology, and then use it properly covering all the country priorities.
Thank you. Thank you very much, Yara, for those excellent insights and reflections on the utility of this from a practitioner perspective, emphasizing practicality and how this has actually been taken in different contexts. So with that, we'd like to have a series of question answers, and I'd like to hand over to Professor Tim Roberton to kick off the discussion.
Thanks, Zubin, and thanks very much to Yara and to the team for the presentation, which I was, thought was really fantastic. One of the things that I thought was great about, this discussion we've had so far today is that we've been talking about how to create a model and a modeling tool that can be actually used by policymakers, so it doesn't remain a theoretical exercise. And that's a big emphasis of the project that Zubin introduced at the start of the webinar. We're really trying to think about how we can make health systems modeling work for policy. And it's great that you mentioned. I feel like this came up in several different ways in your presentation, which was great. So one of the things I think that came across is that you really thought about how to make the tool, the interface, most useful for policymakers, and how to have the process of building the model involve policymakers and therefore be more useful. So I got a couple of questions on this issue of making a model that works for policymakers. So maybe the first question for Sun. I think you said, or I sort of gleaned that, the results of these simulation exercises need to be interpreted with some caution. I think we can all agree that that's what you should do. And specifically, they shouldn't be seen as predictions or as exact forecasts of what's going to happen, right? It's like you said, it's an experiment, right, that you're running. It's a simulation. So Sun, when you're working with policymakers, how do you communicate that to them so that they understand and can interpret and use the modeling results in that light?
Thanks for the question, Tim. Yes, I did mention a bit on how the model helps to validate, project from the present to future and validate to the historical data. So we're using the tool to help us estimate the impact or the effects from the different policy that we try to test or experiment and run projection to the future or simulations of different scenarios. These are the few terms that we're trying to share because we want to be cautious or be mindful that at the end of the day, this is a tool that help us communicate and help decision making. It's a decision support tool. It is not a prediction or a forecast tool like the weather forecast. That is a very high level of confidence forecasting tool, because for weather you could see it's usually quite accurate. But for public health issues that include many different complexities, its health system is not just health system, it's different systems for health and care. So when we bring in different factors into the model, of course, we need to understand the model boundary. And from there, we need to understand, okay, is this uncertainty and confidence allow us to say this is a prediction, or is this a tool that help us understand what are the potential combinations of policy at the population level or regional level to support decision making or policy planning. So this is a brief answer to that question of when we are trying to describe or explain about prediction, forecast, and projections into our projects when we communicate with policymakers. Because at the end of the day, sometimes if we overestimating the confidence or the accuracy, there's also a potential negative impacts in policy translation.
If I can add just to that we usually think about policymakers as one group of people, but it's a very diverse group of people, and different groups, they need different levels of certainty, let's say. So for the high level policymaker, they can absorb, they are comfortable with certain degree of uncertainty. So they are fine with the projections, with the trend, even with the uncertainty around the projection. But then in the same group of policymakers, there are data people, senior data officials, with whom in Sao Paulo, for example, we've gone box by box, data point by data point, explaining where is this coming from, what is the output, what are the implications. So again, it's also like different for different audiences of people using the simulator. There is not a one group, homogeneous group.
Mm-hmm. Thanks. Yara?
Yes, just adding again about the real life, yes, is that at the end we are really using exactly what you said, Tim, about how reliable we could be using these outputs or outcomes. Then we are pushing for the quality of the data. Then we are, since the beginning, understanding that, or sharing them, as Daniel said, that they have no data in several situations. Then they start understanding the importance of some data that they are not really taking about. In most of the case, I can say about what we are learning, they are using data for volumetry. They are measuring production, but they are not really focusing on outcome. And the simulator push us to the outcome. And then when we are showing the impact, for instance, related to the economic impact, this is where they have no data as well, or they have a fragmented data. Then we are using data to make the simulator more and more reliable. We must increase the quality of the data. And then we are really transforming the way they are talking about that. Then we are always saying that the regular word is garbage in, garbage out, and they are receiving well in a sense of improving their quality of the data. We are talking about 45 cities that we are in Brazil.
Mm-hmm.
And imagine that all of them, they are now being touching for the simulator in a simple way, but touching about that reflection, thinking about that.
Mm-hmm.
Just to add in one point that Yara just mentioned, the data comes into the picture because you're mentioning about the interventions, right? So we also use implemented data on intervention. So it goes into operation level. So how many, for example, how many people, how many resources, when is it implemented? How long would it be implemented? What is the capacity per day this intervention can be implemented? So those data, implemented data, is also important to input into the model to understand, are we unrealistically thinking this intervention can be implemented as 5 times more than what the reality is? So just a quick wrapping up for you on this question.
Yeah. Great. Excellent. Well, let's keep talking a little bit about this kind of interaction with policymakers. So, Daniel, I think you started to talk about this, from the outset of the presentation, which was great. So, you've described like working with policymakers, a participatory process to build up the model. Do you think, maybe you could tell us a little bit more about how you approach that, and do you feel like you could do that, with any set of policymakers? You talked about how you just said that they're not all kind of the same, right? There's some policymakers have different priorities, different skills. So what are you actually looking for when you're going to policymakers? What do you think's needed to sort of generate or create that participatory process to build up a model that will be used?
Yeah, thank you. And not easy to answer. So ideally, they will be looking for us instead of us looking for them. That would be ideal. So they will be saying, look, Daniel, we have this problem. Like, how can we deal with it? But it's not usually happening, that's to say.
Yeah.
But then one part that I do think that is instrumental to engage not only policymakers, but different stakeholders is like, when you see these diagrams, social network analysis diagrams, where you have like different dots and lines, and you see one dot that is in the middle of many lines connecting with many different people. That in social network analysis is called brokers, network brokers. I think finding that group that is the network broker that can pull different groups, different people together into having a structured conversation. I think this is what, at least in Sao Paulo, was key. And this was basically Yara, Mariana, the team in Sao Paulo that were basically connecting everyone to everyone, because we love to work in silos. Everyone is in their own silo. And at the end, you need someone that sits in between them and say, look, guys, we all have this hypertension problem. We all have this cardiovascular disease problem. Let's talk. And once you have this ability to bring them in, then the methodology kicks in, where you have structured conversations where everyone has a say, different views, and they see themselves represented in the dynamics that we are exposing. So it's very practical. It's not rocket science. It's pen and paper. I like post-its and paper. It's not difficult. But I think those are the kind of things that really shape. And this is on the positive side. And I think on Sao Paulo, even though Sao Paulo, I think the dynamics in Sao Paulo are a bit more complex than everywhere else. But I think the team in Sao Paulo managed to do an amazing job in connecting everyone to everyone. But then the other part is that, again, these are a diverse group of people, and some of these stakeholders, they have very, very limited time. Having a 1 hour conversation with some of these people is almost impossible. So then you need to manage those kind of time and impact. Not everyone needs to be involved in everything. So you need to probably, what we try to do is we plan it in a way, okay, we will have this time with, for example, with the medical society, super interested, very, very engaged. They have a bit more time. And then some other time for local stakeholders, for other stakeholders locally. But I think these two parts of having an anchor, a broker that can connect to people, and then making a strategy for different needs and different opportunities for contribution, I think is key. We usually think as one group, we do one workshop where we invite everyone. That's useful, but not probably the best strategy, I would say.
All right, thank you.
May I add something?
Yeah, please.
Yeah. Yes. What we are considering the different stakeholders regarding creating or being support a new policies, for instance. We are also working, for instance, with the Brazilian Society of Cardiology. And based on the last publication in Lancet, as you must probably know, that is coming from the European Union about the directions of the agenda for 2035 in chronic diseases. And there they are pushing for focusing on children promotion, in reality, prevention and promotion, children and teenagers and so on. Then using the government program, which calls school and health program, Programa de Saúde na Escola. We are already there with the Cardio for Cities in catalyzing initiative. And then we are aligned with the scientific aspect of the society, adding the program from the government and the direction from the literature. And then we are creating exactly an effort and fully aligned with the new policies regarding prevention and promotion. Then we are reinforcing a public program. We are adding value and numbers for that, which means the question is, if we are really pushing promotion and prevention in a school, can we changing the chronic disease scenario? And then the simulator show it, but we don't know if it's reliable or not, because we still don't have the data. But we are based on the simulator, yes, but we don't know. Then we are also challenging in a positive way the results from the simulator, pushing the real data. And then we think, then we are aligned, for instance, with Fiocruz, and we are thinking, what if we do something regarding gamification? Then can we see that we can put all together and not really thinking that the simulator data is 100% reliable, because it's not. But then it's the creating the engagement, creating the curiosity. I mean, if we are among the researchers, how can we don't have this data? Let's looking for these results. Then I think it's a very positive environment pushing for results, for impact in reality.
Great. I'm going to hand over to Zubin. I think you've got some questions. You're on mute there, Zubin.
Can you hear me now?
Yeah.
Yeah. So thanks, Tim. So my question is to Wang about data, and you discussed adapting the model to different contexts. So what are the practical challenges around data and feasibility of data availability? And we also had a question from the audience about, would you, for instance, have data in fragile and conflict-affected settings to do this? So I just want to understand from your own experience of doing this in multiple settings, whether you've had dealt with varying levels and quality of data and how you really address that.
Yes.
And just before you answer that, I'd like to encourage the audience, any further questions you have, please put them in the Q&A section, and we'll then come to audience questions after this.
Yes. Thank you, Zubin, for the question, and thank you, audience, for asking. So, yes, there are. So to adapting the model to data is not always easy. So we met a lot of challenges, and we acknowledge that not all of them are able to be solved given the data that we have. For example, the data sources we are adapting our simulator to the mentioned open data sources. They themselves has uncertainty too, and they are very clearly have been documenting those uncertainties in their own publications. So if we are adapting to their data, so the best extent is that we are adapting to data that already have uncertainty. So that's something we couldn't eliminate. So, and then the next step is that the data available is not always enough to characterize the model parameters to their best extent. We, just as in showing the slides, we identify the parameters that are not identifiable individually, but sometimes it has to be in a pair or in a multiple pair, like a little category. So in those cases, we must identify them clearly and transparently document them. And then, but we also want to frame this as an opportunity to ask questions when we are engaging with the stakeholders. This helps us to ask them the most effective question. And then we are using this not only as a limitation, but also as an opportunity to get more specific contextualized input from the stakeholders.
If I may add just one element. So the thing is that decisions will be made with data, without data, with good data, with bad data. So what I think the methodology brings is it exposes the data landscape. It exposes, okay, in this area, we do have good data, good quality data. This other area, the quality is not good. And in this area, we have no data whatsoever. Because at the end of the day, this is a decision support tool. Because sometimes from the academic side, we get into this kind of discussions on accuracy. And to me, again, coming back, putting myself in the shoes of a policymaker, I want to understand, like, what is the landscape of the data that is informing this tool, how this tool works. And then I will use the tool plus many other things to make my decision. Because at the end, decisions are made. We cannot wait to have the perfect tool to deliver something that it could be useful for policymakers.
Thank you, Wang and Daniel. So now coming to audience questions. So I'll group them. There are quite a few questions. Great to see the participation. So one question, Jhumpa has a question from how you ensure your model is currently reflecting grassroots reality on a continuous basis. And she asked whether it's through participatory simulated building or data calibration. And there's a second question on uncertainty and accounting for uncertainty. And the question from Natalia Nino is what are the parameters or variables that are considered with the most uncertainty for the topic or context in the case of cardiovascular disease analysis? So those two questions, if you could address those first, whoever would like to take those.
Maybe I can start with the first one and then you continue and then maybe you can take the second one. So for the, like, how do we make sure that the model is still valid and represents the realities of what is going on? And a couple of points. So first is that dynamics of hypertension and cardiovascular disease, they don't change that dramatically from 1 year to the next. So the trajectory that we see is coming for the last 20 years and is continuing for the next 20 years. There could be things that change that trajectory, but we don't need to have data every month to make sure that the model is relevant for the discussions that policymakers are having and for the decisions that they need to make. But then, having said that, so part of the effort that we try to make, and is what Yara was mentioning with Fiocruz, is that the technical capacity is not only with Swiss TPAs. That doesn't make sense to me. So we've been working with Yara, Mariana, with the team, with Novartis in developing this tool. Now, if there is an institution in Brazil, much closer to policymakers in Brazil, that can make this type of adaptations, that can run updates of the model, maybe not only the data, but also the structures of the model if things change, that make the model more relevant because new interventions may come, new effect size may come. So the having a local, sometimes closer to academic institution that can take on board the more technical side of adapting the model over time. I think that's crucial. We are getting there. It's not been an easy task, just to put it out there. So it's difficult to find institutions that we can connect with, that are willing to engage, that already have the knowledge, the know-how. But I think in Brazil we are getting there, and I think it would be a fantastic development that there is an institution in the country where the model is trying to provide answers for, that can work with governments there to adapt and contextualize. I don't know if you want to add.
Yeah, just said it. Thanks, Daniel. And just to add in one point, and you're right. Is it true participatory in your question you were asking? I think it's through different ways. Both participatory and data, because I would see this collaborative effort as connecting different dots together. Either it's different fragmented data that we're trying to understand the data landscape, either through different stakeholders or users of the models, or the impact of the interventions group. So we are trying to connect input from the experts, qualitative, quantitative, relationship building, trust building, ownership building. So I would say it's connecting different dots together that we try our best to represent the best evidence, to connect the best evidence, and to connect the people, the human factor. At the end of the day, there are many tools out there. We need to emphasize it is the human factors, communication of the science, that the tools help to represent the condition, the grassroots condition. Yeah.
Yeah. Okay. Thank you, Sam. So my response would be a bit more focused on the question from Natalia. You asked what are the parameters or variables that are considered with the most uncertainty for the topic or context. I think this is a really good question, but it's also very hard to answer, because partly because our model currently is calibrating to public available data, so we are naturally and inherently inheriting the uncertainties that were baked in their model and their data. So this is there are upstream uncertainty sources, and we also very appreciate the upstream sources are documenting this very transparently. And the second layer would be the model itself has parameter couples and pairs and groups that are structurally not identifiable. So those will be quite just to use data or observe the trend to calibrate. So those parameters pairs, for example, one parameter is controlling the inflow to a stock, another parameter is controlling the outflow from a stock, and then you only observe that stock. Then how could we tell the two parameters from each other? Then that's mathematically challenging. So I would say these are the two layers of the difficulty related with parameter and variable identification, and they have biggest uncertainties around them. So this also paved the way for us to ask the best question to the stakeholders. Thank you.
Thank you to all the panelists. I'd like to now, there are two more questions quickly before we have closing reflections. One is about the question from John Kiragu about transferring this approach to other disease domains such as EMR, and would the fundamental modeling assumptions change? And a second question, whether you have plans for an analysis of an economic burden model, and would you make it open source? This is from an anonymous attendee.
I can go with the first one. So I'm not a modeler. I take system dynamics modeling as kind of a logistic regression. So we can use logistic regression for many different things. So to me, system dynamics modeling is the same. So of course the method can be used for different topics. We are now building a model in Lao, in Vientiane, looking at palliative care strategies for reducing suffering at the national level. So the system dynamic modeling techniques and methods can be used for anything. Specifically for AMR, I think they're especially interesting because AMR is influenced by so many factors, not only human factors, but also animal health. And there are so many connections. They are more than happy to explore that with whoever wants to explore it, with John or someone. And then on the economic model, there is already an economic module in the simulator. So we can produce already cost saving analysis. So the type of questions would be, how much do we save in stroke hospitalizations if we invest in hypertension care, for example, or how much productivity loss we will have if we don't invest in hypertension at this point. So this type of trade-off policy questions with an economic lens currently can be asked to the simulator, and yes, it will be published, and yeah, the paper is coming soon.
So thank you very much for those questions. We had more questions from the audience. Unfortunately, we're quite out of time, unable to answer all of them. I think we've covered a broad spectrum. I'd like to now hand over to Tim Robertson to give some closing reflections.
Thanks, Ruben. And thanks again to the team. Look, I'll just be very brief here. I thought this was a wonderful presentation. And as I said before, I particularly enjoy the focus on how we can make these models be used and how they can actually contribute to policy, which is what we want. I think modeling is very hard, difficult at the best of times, and many people who undertake modeling, they do it in a kind of academic environment, or it's just a kind of theoretical exercise, and it never is actually then used in a meaningful way in the policy space. And I feel like you've gone even beyond that. You're actively trying to make sure that it is used, which I think is unusual. We did a scoping review of at least what's in the literature on health systems modeling. And there's some papers, plenty of papers on health systems modeling, but there are very, very few that talk about actually the involvement of policymakers and what actually came of the model and how people interpret it and use it. So, so I think I'd like to commend you on that. And I think it's fantastic because that's what this project that the Alliance has funded is all about. It's like, how can we make modeling work for policy? And, it's clear that you're not doing this, but you've also thought about it as well. And I learned a lot from what you said today. And I really like some things you talked about: building trust, confidence building at the end. Soon you talked about ownership, connecting people, and the human factor, right? And so I would say let's all take from this that, we really need to remember the human factor, and it can be done, as this team has shown. So again, Congratulations. Thank you. So thanks again to Daniel, Sun, Wang, and Yara as well. I think this has been a great conversation. Thanks to the audience for tuning in, and we will be having another one or two of these webinars this year, and we will share information about them when we have the details. So hopefully we will see you again then. Thank you and goodbye.
Thank you.
Thank you very much.
Bye-bye, everyone.
Bye.
Bye.
Thanks.